Welcome, everyone. Good afternoon. This is the Committee on Health and Human Services, Finance and Policy. Today's date is Wednesday, March 23rd, 2022. We've got a number of bills ahead of us here, so we'll get started right away. And for the record, we do have a quorum, and we'll jump right into our bills. First bill up, Senate File 3566, Senator Clausen. And let's see here. Senator Draheim, would you like to move Senate File 3566 to be before us?
So moved.
Thank you. And Senator Clausen, do you want the amendment moved right away?
Mr. Chair, maybe I could make introduction and then move.
Want to do that
amendment
first? Perfect. Okay, Senator Clausen, if you'd like to introduce or to tell us about your bill. Thank you.
Well, Chair Edke and committee members, thank you for the opportunity to present Senate File 3566. It's a bill modifying the definition of intractable pain and the criteria for prescribing controlled substances for the treatment of intractable pain. And I would like to offer the A2 amendment. The amendment conforms to recommendations by the Department of Health and corrects technical oversights.
Thank you, Senator Clausen. Senator Draheim, would you move the A2 amendment to be before us?
So moved.
Members, we have the A2 amendment before us. All those in favor signify by saying aye. Aye. Opposed? Amendment is adopted. Senator Clausen, if you want to further describe the bill now with the amendment that we just adopted.
Well, thank you, Mr. Chair. In a 2015 letter, the American Cancer Society warned the Center for Disease Control, the CDC, that their guidelines seeking to reduce inappropriate opioid prescribing had the potential to significantly limit cancer patient access to needed pain medications. And I'm going to quote just one sentence they had in that letter. It says, "Our concerns are so serious, we cannot endorse the proposed guidelines in any way." The CDC guidelines referred by the American Cancer Society required a threshold of 90 morphine milligram equivalents, or 90 MMEs, a day. The 90 MME per day is an inflexible cap that has been shown to be inadequate for long-term patients with episodes of severe pain. Patients above the 90 MME threshold are being tapered, meaning their medication dosage is being lowered. In 2021, a letter sent by the American Medical Association, and I quote, "The 2016 guidelines have been devastating for patients with pain and urge the removal of arbitrary thresholds." The AMA further stated, "The CDC's threshold recommendations continue to be used against patients with pain to deny care. The CDC policy has harmed patients with cancer, sickle cell disease, and those in hospice. The restrictive CDC policies also fail patients who are stable on long-term opioid therapy." And in reference to that quote, I just want to bring to your attention, you should have a handout from Ray Blaylock. She's president of the Sickle Cell Foundation in Minnesota. Other states have already taken up action to address the situation. Oklahoma, Rhode Island, New Hampshire, and most recently Arizona have acted to improve access to care for chronic and intractable pain patients. And with that, Mr. Chair, I would like our testifier, our first testifier, Dr. Beth Darnell from Stanford University, to testify. Dr. Darnell, is an expert on patient-centered care, studies on tapering, and has recently been an advisor to the CDC on guidelines revision processes. And she's twice testified in Congress on this topic. And she will be a virtual testifier.
Thank you, Senator Clausen. Welcome, Dr. Darnell, to our committee. I see the slides coming up here, so please identify yourself for our record and then proceed with your testimony.
Thank you so much. I am Dr. Beth Darnell. I am a professor at Stanford University in the School of Medicine in the Department of Anesthesiology, Perioperative, and Pain Medicine. As Senator Clausen introduced me, I served on the 20 CDC opioid work group advising on needed changes to the current guideline, have advised the FDA on harms perpetuated to patients during tapering, and have twice testified to the US Congress on this topic. Now, we know that opioids should not be a first-line treatment for chronic pain, but they are medically necessary for a fraction of patients with complex medical conditions. In 2016, the CDC published its prescribing guideline for opioids, and at that time, 11 million Americans were taking daily prescription opioids to manage their pain. At that time, there was a rush to deprescribe, to come into alignment with these so-called thresholds, dosing thresholds. And this rush to deprescribe resulted in grave consequences for a fraction of patients, truly horrible consequences. Now, when people are taking daily prescription opioids long-term, their bodies adapt to the medications, and any changes must be made to doses must be made very carefully and only in patients for whom this is the right medical strategy. This requires clinician discernment and medical skill. So the problem is that what we've seen since 2016, there's been a lack of policies that support clinician discernment and the patients who need medications. There's been application of a one-size-fits-all approach that assumes that everybody should taper. This has perpetuated risky, forced tapering practices that have led to patient harms. These are just a few of the studies documenting patient harms from rapid and inappropriately implemented tapers, including overdoses, suicidality, mental health crises, suicides, and for those who survive opioid tapering, difficulty accessing needed medical care. Rather than having policies that focus on a dose threshold or the medications, we need to treat people who have chronic pain. In 2018, my team and I published the first study on community-based tapering, which provided the data to show how to taper successfully. This was a voluntary tapering study in alignment with Health and Human Services guidelines. Voluntary opioid tapering practices are best. We optimize patients' voice and choice in the taper and how the taper is implemented. They can control the pace, they can pause their taper, they can stop their taper if they want to. We don't force people to any particular dose. Rather, we help them achieve their lowest comfortable dose over the course of the taper or the study. And most importantly, if people needed to increase their dose, we allowed that. Now, I just want to draw your attention to the yellow line. What we showed was that when we apply voluntary patient-centered tapering methods, that patients successfully reduce their opioid dose by about half in 4 months, and we're able to show that we're keeping patients safe. They're not deteriorating as their medications are being reduced. And this is truly overlooked in other studies. Now, what happens to people's pain when they go through a voluntary opioid reduction? Well, on average, most people's pain does not increase. But here's where I want to draw your attention to these dots in the circles. Each dot is an individual patient in our tapering program. For some patients, their pain did increase as opioids were reduced. And for some patients, their opioid dose did increase. These are the outliers that provide evidence and demonstrate why we need flexible policies so that we can meet the individual needs of each person living with pain rather than forcing them into policies that could potentially harm them. I was pleased that the 2019 Health and Human Services tapering guidance heavily borrowed our methods from the study I just presented. We have been conducting now a 5-year patient-centered opioid tapering study that uses these same patient-centered methods. We're studying 1,400 patients in 5 states. This is a voluntary tapering study, and it is funded by the Patient-Centered Outcomes Research Institute. We train clinicians how to work with patients to understand their needs, their wants, and better meet those needs and wants. And we really and truly need to create a safe and caring environment that patients want to join and remain in, because remember, this is a voluntary operation. Now, how do we do this? By tracking them very closely. We deploy weekly e-surveys, monthly e-surveys, asking patients in their own words to tell us how they're doing so that we can identify problems early on and address them immediately. Patients tell us that they're receiving even better care because we provide them with electronic safety nets. These methods align with the 2019 Health and Human Services guidance around how to best taper and how to best support patients. And I would like to offer the state of Minnesota all of our established systems at no cost. Our voluntary opioid tapering methods, our entire patient e-reporting system to assure their safety and their comfort. And we also have brief and digital patient supports to align with some of the HHS guidance on needed supports for patients. In closing, I just want to say that opioid tapering is not right for all patients. Without applying right methods, health risks increase. Minnesota policies must reflect patient variability and protect prescribing for clinicians and the patients who need opioid medication. And with that, thank you very much.
Thank you, Dr. Darnell, and please stay with us here a little bit. We've got two more testifiers, and then we'll get to our questions from members. So next up, we have Dr. Sager.
Yes.
Welcome to our committee, and please identify yourself and continue with your testimony.
Well, Mr. Chair, members of the committee, thank you for allowing me to testify today on this important Senate File 3566 authored by Senator Clausen. I'm Dr. Lou Sager, and I represent the Minnesota Society of Interventional Pain Physicians. I'm board certified in anesthesiology and pain medicine. I've been in practice as a pain specialist for over 30 years, and I have a number of peer-reviewed publications in the field of opioid and analgesia. I testify today in support of this critical legislation. My society understands the intersection of two public health challenges: safe and effective treatment of chronic pain while preventing harm from abuse and diversion of opioid medications. Despite resistance from other medical associations based on fears of a chilling effect on legitimate prescribing for chronic pain patients, our society spearheaded enactment of the prescription monitoring program. The PMP effectively stopped doctor shopping. But unfortunately, our colleagues' fears have come true. Guidelines released by the CDC in 2016, which were intended for primary care providers, not interventional pain specialists who treat and manage complex chronic pain patients, have interfered with legitimate prescribing with serious detriment to patients. While those guidelines are supposedly voluntary, fearing legal and regulatory consequences from state and federal agencies, many doctors cut back or stopped prescribing opioids altogether. It's not paranoia. MSEP members have received threatening letters from the Minnesota Department of Human Services. We constantly fight payers, pharmacy benefit managers, and pharmacies that refuse appropriate prescriptions based on guidelines intended for primary care. Ensuring that regulators, pharmacies can't deny a prescription solely based on opioid milligram equivalents will support good patient care. Making it difficult for doctors to prescribe opioids for legitimate chronic pain patients does nothing to reduce opioid abuse and diversion, but it does cause unnecessary suffering and serious consequences for patients who were previously doing well. Please pass this important legislation. Thank you.
Thank you, Doctor. Next up, we have with us Laura Johnson. Coming up behind you.
There she is. I know our testifier had difficulty parking, so she's been harried here a little bit.
Thank you.
Welcome. Welcome to our committee. Please just identify yourself for the record, and then you can continue with your testimony. And I'll just say it ahead of time, make friends with that mic because we want to hear what you're going to say.
Okay. My name is Laura Johnson. I have suffered with chronic pain for over 20 years. I have MS and a deformed spine. The vertebrae in my spine have fused together so they're straight. I can no longer sit, I can't sleep, and I can't walk. I functioned great. I was able to work for the state of Minnesota, Department of Public Safety, helping people get their driver's license back. Had founded a nonprofit organization, finding homes for over 7,000 cats and kittens, find loving homes. I've given all of that up. Was forced to retire, and now I live in a world of darkness and despair. I lost my quality of life, and now it's in existence. I don't have a pain doctor anymore. I got dumped because he was so afraid of the fear of the DEA and the guidelines. So he basically abandoned me. Chronic pain patients are not provided any resources, and are left to fend for themselves. Many have turned to the streets out of desperation. Many more have ended their lives and are suffering through suicide. Suicide rates have skyrocketed over 400% in the last year among chronic pain patients. An option no one should have to consider. This one-size-fits-all approach is sacrificing one population of people for another. The most vulnerable group of people there are. They shouldn't have to fight for the right to live a comfortable life. None of us have done anything wrong. I am begging you to please, please give us back some quality of life. Let the doctors treat their patients with the care they deserve. We're exhausted from hurting. Thank you.
Thank you, Ms. Johnson. Members? Senator Klein.
Thank you, Chair Utke and Senator Clausen. I have a question for council for Ms. Kavanaugh. Page 3, line 17. Are we missing the words limited to after the word not?
Ms. Kavanaugh.
I'd like to offer a verbal amendment, Mr. Chair.
Okay. That's on, would you?
Page 3, line 17, after not, insert limited to.
Okay. 16. Or 17, okay. No. Okay. Ms. Kavanaugh, just adding, do you want to just repeat what that amendment will be, the verbal amendment?
Sure, Mr. Chair and members. On 3.17, after not, insert limited to.
Okay. Everyone's heard the amendment. All those in favor signify by saying aye. 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 Opposed? The amendment is adopted. Senator Abeler.
Well, thanks, and thanks, Ms. Johnson, for coming. I appreciate that, and I wish this place was a little easier to get around for the public as they try to get here. But I'm happy to be an author on the bill, and I think I'm not going to repeat what anybody said, but I think you said it as well as anybody. And so there was a problem in the past, overcorrected, and I'm just so sorry that some individuals had to suffer. So I'm happy to be an author of the bill, one of the co-authors, and thanks Senator Clausen for bringing it forward. And let's get this done. Thank you.
Thank you. Senator Draheim.
Yeah, thank you, Chair Utke. Thank you, Senator Clausen, for bringing this forward. I think it's much needed. We were kind of warned that this might happen. So thank you. And, you know, to Ms. Johnson, thank you for making the trek. I know, like Senator Abeler said, the handicap parking around the Capitol is awful. And it's one thing we got wrong up here is it really hard to find handicap spots or people with mobility issues. So thank you for making the trek up. I appreciate it. And Senator Clausen, I would take that 5th spot on this bill if you got it open.
Thank you. Members, further questions or comments? See none. Senator Clausen, if you would like to make some final comments, and then we will move your bill.
Yeah, thank you, Mr. Chair. Just a couple points. There's a number of handouts that you have, and I hope that you have a chance to look at them. I want to, in particular, point out that there'll be a multi-page handout that'll be sent to you. It has over 300 names of people who wanted to testify on this bill. And 270 of them are from Minnesota. There's another 30 plus that are from other states. And it's a very moving testimony, and it again provides insights. But just as a final comment, there does continue to be an opioid crisis in America. The threat is primarily being driven by illicit fentanyl on the streets. While prescribed opiates have dropped 60% since 2011, overdose deaths reached a record high last year. Those suffering from intractable pain and unable to access medication have been a part of the collateral damage in this healthcare challenge. And so I deeply appreciate your support on this bill. So thank you.
Thank you, Senator Clausen. With that, Senator Draheim, would you renew your motion that Senate File 3566 be recommended to pass as amended and sent to the Committee on Civil Law?
So moved.
Thank you. All those in favor of the motion, please signify by saying aye. Aye. Opposed? Motion passes. Thank you, Senator Clausen. Thank you, Ms. Johnson, and thank you to the doctors who joined us online. So with that, next up we have Senate File 3071 brought to us by Senator Rosen.
Mr. Chair,
Senator Abeler.
I'll move the bill.
Okay, thank you.
It's nice and
Okay, it's welcome, Senator Rosen.
Thank you, Mr. Chair. Thank you, members. I have Senate File 3071 before you, which establishes the board processing procedures for physicians, physician's assistants, and respiratory therapists, and also modifies the length of time a temporary permit issued to the Board of Nursing is valid. Members, Mr. Chair, this bill is before you because of the extraordinary lessons we have learned from the COVID pandemic. And COVID has brought so many things to our attention, but one significant lesson we need to look at is modernizing the process of licensing and expand the availability of temporary permits for qualified providers so they can do their job and care for Minnesotans. As you've seen, there's been a lot of talk about this in news articles, and I know this committee is acutely aware of the shortages when it comes to our workforce, especially in the healthcare arena. But it's not always the same story for Minnesota as we've seen nationally. However, there was in Minnesota a short-term emergency during our COVID surge where hospitals were desperate to hire respiratory therapists but could not attract any national talent because of the licensing process, which is taking months to complete. Professionals were not willing to come to Minnesota without being paid, and they couldn't start working without a license. A temporary permit helps address this challenge. Also, national recruitment of healthcare professionals who plan on staying in Minnesota, like our surgeons, our cardiologists, our ICU nurses, our pediatric oncology nurses, can begin work immediately with a temporary license without unnecessary delays. And Mr. Chair, there is the delete all A2 amendment before you.
Okay. Thank you, Senator Rosen. Senator Abeler, would you move the A2 amendment?
So moved, Mr. Chair.
Thank you. Members, we have the A2. All those in favor, please signify by saying aye. Aye. Opposed? The amendment is adopted. This is the A2 delete all amendment. And Senator Rosen, I have notes here. Do you want to do the next one right away?
A4, yes, please.
Okay.
That was just an omission that deals with the foreign students statute on line 8 of the A4 amendment.
Okay. If you would like to move the, let's see, Senator Abeler, would you move the A4?
Thanks, Mr. Chair. I'm against omissions. I'm in favor of the A4.
Okay.
So moved.
Okay, the A4 amendment is before us. Members, any questions on the A4? Or do you have a copy of it? Okay. Seeing none, all those in favor of the A4, please signify by saying aye. Aye. Opposed? The amendment is adopted. Senator Rosen?
Thank you, Mr. Chair.
We've now got your bill in the form you'd like it.
You bet. Thank you so much. So this bill provides a temporary non-refundable permit for physicians' assistants, respiratory therapists while applying for their licensure. Currently, if they are licensed to practice and is not subject to a pending investigation or disciplinary action in another state, territory, or Canadian province, a temporary permit is issued, is non-refundable, and shall remain valid until a decision is made on the application for licensure for up to 90 days or whichever comes first. The Board of Nursing was 60 days, and now we're expanding it to 90 days. And the original bill, the original Senate File 3071, called for a temporary permit of 120 days. But after looking at some research of state licensing laws, 90 days is the national average. And members, there should be a little packet or a little sheet here that talks about what all the other states are. And you can see where Minnesota now will be about the average, which will be wonderful. The Board of Medical Practice in this A2 amendment will go from 30 days to 90 days. It is not my intent, Mr. Chair, members, or desire of this bill to reduce licensing standards or to change licensing requirements, but to facilitate getting individuals through the process in a more timely manner. The difference between the compact bill and Senate File 3071 is the compact bill is licensed in home states. Senate File 3071 as amended allows temporary license through board while applying for licensure. And Mr. Chair and members, I would just like to give a special shout out to Mary Krinke with the Hospital Association, Ruth Martinez from the Board of Medical Practice, and Kimberly Miller with the Board of Nursing.
Somebody's...
We've had...
Somebody's got F4 probably
good?
pushed.
Ah, there we go.
Or unlock it. Let's try it again.
Oh. Well, I just wanted to give a shout out to Ms. Krinke and Ms. Martinez from the Board of Medical Practice and Ms. Miller from the Board of Nursing. We've been in discussions. There's been several meetings, and this is a great compromise that came together. And I'd like to have them testify after Ms. Krinke, if that's possible.
Yep. Thank you, Senator Rosen. And yes, we have 3 testifiers listed. And first up is Ms. Krinke. So welcome to our committee. And You know the routine. Please identify yourself and
Good.
proceed.
Thank you, Mr. Chairman and members of the committee. For the record, my name is Mary Krinke, and I'm with the Minnesota Hospital Association. We were hearing from a number of our members that they were quite frustrated with the licensing process, that they just felt it was taking too long. And, you know, when your members are frustrated, they complain to you, and so they want action at the Capitol. Well, since then, I came to learn that many of the applications that do come into the boards were quite simply missing information that the boards needed to process the license. So it's kind of this catch-22. They can't move forward unless they have all the information, but people don't necessarily always know what information is needed. And so where we landed was recognizing that you really do need time for a temporary permit in order to get everything in that is needed to move forward with the licensing process. And so we started looking around at what other states have, and we found that this 90 days seems to be kind of an average. A lot of states actually have 6 months, but we really felt that moving to 90 days would be very helpful. And I would like to share a story from the pandemic, as Senator Rosen mentioned. On May 28th, the governor's executive orders ended, and they ended pretty quickly. And what happened then, at that time, we had a number, particularly ICU nurses that were here in Minnesota working, as well as a number of respiratory therapists. And so we realized then that the nurses had a 60-day temporary license process in place. And we were able to work with the Board of Nursing and get as many of those ICU nurses as we possibly could through the licensing process as quickly as we could. It was a pretty short window, and we realized that that 60 days was really tight and that it would have been better if it could have been 90 days. But we also quickly learned that there was nothing in place for the respiratory therapists, and we literally had to send numerous respiratory therapists back to their home states or to other travel positions because they couldn't stay in Minnesota without being licensed. So as we think of our workforce shortages moving forward, we just recognize that having a temporary license process in place, a temporary permit process, it's a temporary permit process, and having this in place and working with the boards to where they felt comfortable with moving forward, that this would be a good step for us to have in order to both bring in healthcare professionals who want to do this on a short-term basis, but also, as Senator Rosen said, in our national recruitment of healthcare professionals from around the country who want to come and stay in Minnesota, being able to work while they do the licensing process is good for both them and for hospital and health systems. So I'm really hopeful that we'll be able to get this across the finish line, and I stand here for any questions that folks may have. Thank you.
Okay. Thank you. We'll take the next two testifiers, and then we'll move on to questions. So next up, Ruth Martinez. Welcome to our committee, Ms. Martinez.
Thank you, Mr. Chair, members. I'm Ruth Martinez. I am the Executive Director of the Board of Medical Practice. And I just want to say thank you to our authors, first of all, and to all of the stakeholders in the healthcare system that have been in conversation with us over these last 2 years, highlighting the challenges, helping us contemplate what solutions might work, and being really receptive to some of our feedback along the way. So I'm tremendously grateful for the acceptance of the A2 amendment that really does provide not just a short-term emergency solution to a healthcare crisis, but really provides both the short-term and a long-term solution through this temporary permit process. We applied this to the Medical Practice Act, to the Physician Assistant Practice Act, and to the Respiratory Therapy Practice Act, already understanding that the nurses had this in statute. It was working really well for the Board of Nursing. I know Ms. Miller will talk about that. And really, you know, providing the opportunity for us to get people into the workforce expeditiously while we process that full license. So I think this is an outstanding solution for all of us. Gives the board time to process, gives those individuals time to get into the workforce and get to work when our patients need them. And thank you very much for entertaining this bill.
Thank you. And welcome to our committee, Ms. Miller. And so if you'd like to proceed with your testimony. We'd love to hear it.
Thank you, Mr. Chair, and thank you, members of the committee.
And I'll have you
Okay,
make friends with that mic because they
Okay.
just don't pick up real well.
thank you. Thank you, Mr. Chair and members of the committee. My name is Kim Miller, and I'm the Executive Director of the Minnesota Board of Nursing. The Minnesota Board of Nursing has been using the permit process for our registered nurses and licensed practical nurses in the state of Minnesota for quite some time. These are nurses who come to the state by endorsement, and the moment that they submit an application for licensure, they're eligible for a permit, and that permit is typically issued within 5 days of receiving that permit or the application, and they're eligible to practice then while we continue their application process, complete their criminal background check and those kinds of things. We are in most situations, we're able to license individuals within the 60-day period of time. However, as Ms. Krinke also alluded to, there are some times when we could use additional assistance, especially, or additional time, especially when we have a surge of nursing staff that are coming in from other states for a specific reason. And so after the executive order was no longer in effect, we really had to take a close look at how we were going to manage this, and the 90-day extension from 60 days is really very beneficial to the Board of Nursing in managing this as well.
All right. Well, thank you very much. Members, comments or questions for Senator Rosen or our testifiers? Senator Klein.
Thank you, Mr. Chair, and thank you, Senator Rosen, for bringing the bill. You know, fairly impressive work on getting stakeholders in one room and getting everyone to support this bill, the Board of Medical Practice. It's very helpful. Thanks so much. I know you won't be around with us next year, Senator Rosen, and hopefully we can learn the lessons of how you manage your legislation so diplomatically and to carry that forward here in the Senate. And just to make sure for my own clarification, in the original bill, there was a process for licensing navigators or something like that. Has that been removed in the A2?
Senator Rosen.
Thank you, Mr. Chair, and thank you, Senator Klein, for the kind words. Yes, that has been removed. It's not necessary. And there, I actually would allow our testifiers to talk about, there was a few things that we did want to put in there, but the argument is very compelling why it's not necessary, and that was one of them.
Senator Klein.
Thank you, that's him.
That's it. Okay. Senator Benson.
Thank you, Mr. Chair and Senator Rosen, and to the medical boards and the Hospital Association. COVID taught us many things, some very, very hard lessons. And Ms. Miller, the first time you and I had a conversation, it was about how do we get these licenses through? And you were brand new, dug in and helped get more licensed nurses into our system. And so of all the lessons we're going to learn out of COVID, our workforce shortage isn't going away. And I hope this helps our health systems become more flexible as they meet the needs of patients, and helps maintain the high standards that Minnesota has always had for our licensed professionals. So thank both of you for your work with Senator Rosen in getting something done this year. And now, Mr. Chair, let's hope the House cooperates. And I know we're not supposed to mention the other body, but this is one of those things that does need to get done if we're gonna take any pressure off our workforce. So, Mr. Chair, when we're ready, I'd move this bill.
Okay, thank you. We have Senator Nelson.
Oh, thank you, Mr. Chair. And Senator Rosen, I just wanted to really thank you for bringing this bill and working hard with all the stakeholders to get it across. And I know that the board, the medical board, is very helpful as these things go forward. But just to really kind of echo, my thoughts were similar to what Senator Benson was saying. I mean, we have all learned a lot of lessons through this COVID pandemic, and I think it has helped us embrace the future a little bit better. It has moved us along in using things like telehealth, something you've been very involved in, and licensure is so important, specifically with telehealth, but also in general to make sure that we have the full workforce that we need. And I guess the only the temporary permits, they're still temporary permits, so that's good to get those temporary permits out the door sooner. But then how do we make sure that we actually have that workforce on a more stable, long-term basis? And I know that's something further that we'll continue to work on, but I think this is really a good step in the right direction. And I did hear you mention respiratory therapists in your comments, which is so critically important. They reached out to me early on in the pandemic, and I think if we didn't know much about respiratory therapists before, we definitely do now, and how important their work is. So I just want to echo my support for this bill.
Thank you.
Thank you. Any further comments, questions? Seeing none, Senator Rosen, if you would like to make some final comments?
Thank you, Mr. Chair. Is this going to general orders, or is this getting laid over? General orders?
This is going to general
Thank
orders.
you. Thank you. I appreciate that.
As Senator Benson said, now we got to get the other body to make sure they do the same.
Yeah, that's right. Well, I just a couple comments, and thank you, Senator Klein. Your negotiating is exemplary too. I did propose an A3 amendment with Ms. Martinez and Ms. Miller this week, or last week, I guess it was, and that would require some notification for the applicant within 30 days of receiving the application if something was missing, because that happens a lot. And if you don't mind, if they could just tell you the application process, I think the level of scrutiny and this discussion about this bill has brought everybody's attention to how the process works, and I think this would be really good. We're not pushing that part of the legislation because I really think the two boards are doing it well. So if you could just mention that, Ms. Martinez.
Ms. Martinez?
Mr. Chair, members, thank you. Senator Rosen, thank you for asking that. I think one of the things we talked about this week when we met was the process that we have for notifying applicants of the status of the application and any items that might be missing in that process. I know I don't want to speak for the Board of Nursing. I'll let Ms. Miller speak to their process because I think they have an online process at the moment. The Board of Medical Practice is in conversion to a new database, hopefully within the next month, that will also have an online status update for applicants. They'll have an online portal, and that will be tremendously helpful for letting everyone know what's missing, when it's arrived. But in the meantime, we are notifying applicants very quickly. As soon as we pick up that application file and review it, we send a notice out to applicants and let them know exactly what is missing in their application. I do think the online portal is going to really enhance that process. So thank you, Senator Rosen. Thank you, members.
Ms. Miller, did you want to weigh in on that one too?
Sure.
Or no, that was just...
I can if...
Yeah, please.
Okay. Thank you, Mr. Chair. The Board of Nursing has a process where when an individual applies, they're also prompted to sign up for a portal so that they can monitor their application throughout the process. It shows them, they can open up their page and it shows them exactly where we are in the process. The other piece is that the Board of Nursing, if we receive an application that is incomplete or has some inaccuracies on it, is missing parts of it, it's returned to the applicant with the information about correcting that. And so they have communication from the Board of Nursing. We also run a telephone center so that they can reach somebody in person. The other pieces that we also we belong to the National Council of State Boards of Nursing, and they have a process called the Nurses Program, and that is where we can review anybody's history in any state for any disciplinary action ourselves before we authorize a permit. So we do have that in place as well. So we and then the most recent thing that we've added now is an email blast that we send out to applicants when there's something that is missing from their application, and it goes out at 30 days. It goes out again at 60 days. It will go out 15 days before their application is ready to expire if they don't, or their permit is ready to expire, and they haven't gotten all of their application pieces in.
Thank you. Senator Rosen, anything further?
No, that's fine. Thank you
Mr.
very
Chair.
much, Mr. Chair. The reason I wanted to bring those two issues up is because at some point next year, I will not be here. Can you have a conversation about Minute? It's costing a fortune. It's driving the boards crazy. We tried to deal with it a couple years ago, And I think now is the time to start preparation. We don't know what we have, what our future holds, but certainly we can learn from our lessons going forward. And I think this is a perfect example of everybody getting prepared and working together.
Senator Rosen, we're not going to let you go quite yet. Senator Benson.
Actually, Mr. Chair, I'm not going to move the bill. Senator Abeler is going to do that. But I have the Finance Chair and the Board of Medical Practice Director here. And I have a bill that is digital fingerprints, and we need to figure out how to cover some cost of a technology adjustment based on that bill. So there'll be a fiscal note coming forward, and so I'm just thinking maybe Ms. Martinez, as long as she's doing this technology upgrade, could just incorporate that work and save me a fiscal note for Senator Rosen. And so that's a comment more than a question to put them on the spot, Mr. Chair.
Thank you. Okay, we're going to go back to business at hand here. Senator Abeler, would you remove your motion, or renew your motion that Senate File 3071 be recommended to pass as amended and sent to general orders?
So moved, Mr. Chair.
Thank you. Members, we have a motion before us. All those in favor signify by saying aye. Aye. Opposed? Motion passes. Thank you, Senator Rosen.
Thank you, Mr. Chair. Thank you, members. Thank you, Senator Blair.
Thank you so much.
Welcome, Senator Draheim. Would you like to move your bill to bring it before us?
Thank you, Chair Key. I guess I would like to move Senate File 3574.
Okay, thank you. And Senator Draheim, do you want to introduce your bill? I see you have an amendment. Do you want to do that right up front? Or do you...
I think we should do the amendment right away, and then it's in the order. But I think that it can move forward.
So we've got, if you would like to move your A1 amendment.
So move.
Okay.
A1.
Members, we have the A1 amendment before us. It's pretty brief, but it's got an important feature. Do you want to just tell us what it is? And everybody will know why the amendment's in place.
Well, we're deleting the fiscal portion of the bill.
Yep.
And that's plain and simple, just to keep the bill moving.
It removes the funding increases.
Yep.
Okay.
Yep.
Perfect.
Thank you, Chair.
Members, all those in favor of the A1 amendment signify by saying aye.
Aye.
Opposed? Same sign. The amendment passes, or is adopted. Senator Draheim, to your bill as amended.
Thank you, Chair Key and members. Senate File 3574 builds on a very successful health prevention program the Senate has invested in over several budget sessions, specifically around helping at-risk mothers maintain healthy pregnancies and prevent fetal alcohol spectrum disorder. Proof Alliance is our statewide partner in those efforts and helped launch this as a pilot program almost a decade ago. Over time, they've demonstrated success, and the program footprint has expanded in the state. As this program matures, it has become clear that it is a better fit to have this program under the Minnesota Department of Health, where the Proof Alliance base budget resides and a long-standing partnership with the state government exists. So that's just a broad background on the bill, Chair. And I guess if we could go to the testifiers, I know we're running short of time. So.
Okay. Thank you, Senator Draheim. And yes, first up, we've got Ms. Massell.
Thank you.
Welcome to our committee.
Thank you, Chair.
Chair Atke and members of the committee, my name is Sarah Messelt. I'm Executive Director at Proof Alliance, which is a nonprofit organization dedicated to preventing fetal alcohol spectrum disorders, FASD, and supporting all Minnesotans impacted. I appreciate the opportunity to testify in support of Senate File 3574, which supports FASD prevention grants for women with substance use disorders. I'll be brief. The overall goal of this program is to reduce the number of alcohol-exposed pregnancies in Minnesota. Currently, 1 in 7 pregnancies in Minnesota are exposed to alcohol, which results in FASD, the leading cause of preventable birth defects and disability in Minnesota. But with the right supports, women with substance use disorders can maintain sobriety and lead healthier lives with their children. This funding, which many of you have supported through the years, has resulted in remarkably effective prevention strategies for moms. The results speak for themselves. 93% of pregnancies to moms in this program are substance-free, and these are moms that have been incarcerated, have had challenges with child protection, and are truly at risk. The program costs $2,300 per family, or about $700 per year. 100% of the client's children receive physical health care, including preventative care, wellness checkups, immunizations, and dental care. The women in the program, often who have been incarcerated, homeless, and living in poverty, are on track to financial stability, getting their GEDs, enrolling in community college and vocational training. In conclusion, these prevention grants have proven to be an effective way for Minnesota to prevent alcohol-exposed pregnancies and to reduce the rates of FASD. It reduces involvement in child protection, improves physical and mental health outcomes for women and kids, and helps women to maintain sobriety for long term. All, as I'll repeat again, at the cost of about $700 per year, $2,300 per family. Our respectful ask, as Senator Draheim has articulated, is to move the grants from the Department of Human Services to the Department of Health. The funding aligns with Proof Alliance's current base grant at MDH and is a public health and prevention approach that can be more effectively administered at MDH. Thank you very much for your time.
And thank you. Next up, we have got, I hope I pronounce this, is it Lynn? Oh, there she is. Okay. Welcome to our committee. Please identify yourself for the record and then proceed with your testimony.
Sounds good. I'm Lynn. I'm the Chief Clinical Officer at Wayside Recovery Center. And I just want to let everyone know that I'm so grateful for this opportunity to express the ways that Proof Alliance and Wayside have collaborated to serve our communities. In substance use disorder treatment, clients meet with counselors, case managers, peers, and additional support staff who are part of the integrated care team. These ancillary services are vital to the success and longevity of their recovery. The structure of substance use treatment has not provided the ability for individuals to have long-term recovery support services outside of a treatment setting. And as clients approach the discharge from residential treatment, many of them struggle with the questions of what happens next. The majority need housing, and many of them also leave treatment with new babies, often their first. The services and support made available by funding from the Proof Alliance have assisted many women with establishing next steps before leaving treatment, as well as supporting them through these transitions once they left. This type of support greatly reduces the stress and anxiety of early recovery in the This type of support greatly reduces the stress and anxiety of early recovery in the community and can reduce the likelihood of recurrence of use. This funding has allowed Wayside to support individuals for up to 2 years post-treatment. Success during the initial 2 years of recovery is critical, and because it greatly increases the chance of lifelong recovery. Long-term wraparound services provide consistency, security, and is an important addition to their support network. The expertise of case managers and peer recovery support specialists help to bridge individuals in recovery to community services that are available to them. These connections aid in their transition back into the community, and this continued support solidifies the capacity to maintain sobriety, effectively parent, secure employment, and establish the foundation of lifelong recovery. I'm so grateful to be able to share about some of the stories and successes of our clients that are here at Wayside. there was a specific client that came to mind where she, when she initially came to Wayside, was able to work with her Proof Alliance and be able to establish housing, be able to establish housing, and also being able to have funding for her children that were there. When COVID-19 hit, there was a lot of instability that happened with her housing, with just being able to provide for her children, and Proof Alliance really stepped in to help wrap around those services for her and help support her through that transition. And I just want to be able to express the gratitude that I have for that funding and for Proof to be able to support these women that are in our care.
Okay, thank you. Next up, we have Justin Breaker joining us. There he is. Welcome. Please identify yourself for our record and then proceed.
Thank you, Mr. Chair. My name is Justin Breaker. I'm a program supervisor with Family Service Rochester. Thankful for this opportunity to share a story about a mother who went through our program, the Family Advocacy and Recovery and Restoration Program that we have at the Family Service Rochester. So the client that I'll share is a name change due to confidentiality, but Ellie received case management and support from Rochester Family Service Rochester. She had recently moved to the area and had left a relationship that was unhealthy and filled with domestic violence. When she first connected with FSR, she was about 6 months pregnant. She had also had 2 of her other children removed from her care due to past use with substances. Quickly, the program got her engaged with programming and peer support groups in order to connect her with other moms in the area that were actively in recovery. The program helped her continue with her schooling and provide transportation with her to get to medical appointments and doctor appointments for the baby and herself, and classes so that she was able to continue to work on her education while maintaining a healthy pregnancy. The program also was able to help connect her with housing resources where she was able to move into an apartment that provides case management services as well as many financial resources. The FSR program case manager was also there to help provide her with support while she went through the process of submitting court documents to regain custody of her other children that were previously removed. In October, this mom gave birth to a healthy baby boy. Although he was born about 4 weeks early, he has continued to impress his pediatricians with phenomenal growth in height, weight, and overall development. The mother has also continued to impress her professionals that she works with. She is getting ready to complete her general education diploma with plans of transitioning to the community college in the area to work towards her license for alcohol and drug counseling. She has been approved of court hearing and is looking forward to it in hopes of regaining custody of her other children. There's been a lot of collaboration with other community agencies while working with this mother. FSR program has collaborated with parent support and outreach workers, family support and assistance of Olmsted County to navigate her housing and financial benefits, a representative from Skyline Incorporated for continued housing support, Olmsted County Public Health for parenting education, and mental health therapists from Zumbro Valley Health Center. The collaboration has ensured this mother is receiving wraparound services that can best support her and her children while she continues to navigate motherhood while in recovery. Thank you.
Thank you. Members, questions or comments? Senator Wickland.
Thank you, Mr. Chair. I just want to comment about, it seems like a really impactful program, and it seems like a really efficient way to use grant money to serve a lot of families. So I appreciate that you're bringing this forward. I also appreciate that it has a provision to collect some data and create a report, which I think is helpful to us to see, to see what kind of impact the program is having. Just a question about, did you want the report, and maybe this is a question for Ms. Kavanagh, about the report on line 2.6 to go to the Commissioner of Human Services, or should it go to the, if this is going to be transferred to the Department of Health, I don't know which department you want it to go to.
2.6.
Ms. Kavanagh, did you get the question? There you go.
If you want to change it to health.
Mr. Chair and members, on 2.6, it should be delete human services and insert health.
Okay, thank you. So we'll make that as an oral amendment from Senator Wickland?
Yep. So
Okay.
moved.
All those in favor of the oral amendment, please signify by saying aye.
Aye.
Aye. Opposed? The amendment is adopted.
And
Senator Wickland.
yeah, and then just another question, I guess, transferring the grant program to the Department of Health. I don't know if you had any comments back from the Department of Health about administering the grant and how they pay for the administration costs in having to do that. And I don't know if the department wants to comment on that. I just want to make sure that as things get transferred to the department for their responsibility, that they have a means to administer the grants.
Senator Draheim, or should we have with us we got a representative of the department too? Or
Sarah can comment on that too.
Okay,
And then if we
Ms.
want to go
Massell?
Sure. Thank you, Chair. Senator Wickland. I think what's important to note is that what we hope is that over time we'll build on our existing partnership with the Minnesota Department of Health. Proof Alliance has a longstanding base grant with the health department, and our hope is that we'll build in administrative efficiencies for both our base grant and these prevention grants. Proof Alliance administers all of the subgrantees, and so it's really an appropriation to DHS or MDH, and then we do all of the requests for proposals, we do all the technical assistance and all of the subgrant management. So what we're hoping is if we can get this bill passed this session, we can line up the funding at MDH for the next biennium, work with our long-term partners there, buy us some planning time with MDH, and make sure that it works better for MDH efficiently for us and for the subgrantees. And so I think we've got some time to work out those logistics, but certainly appreciate the comment about the fact that it's important to make sure we're looking at all of the costs that are involved with administrating the grants.
Senator Wickland, okay. Senator Nelson.
Oh, thank you, Mr. Chair. Senator Draheim, I am just so glad to see this bill. I would just note that probably about 10 or 11 years ago, Olmsted County developed the CRAFT program. And I would just say in that very first year, 100% of the babies born with the mothers who are participated in the CRAFT program were born drug-free. That is a huge, huge saving for those children. And also, if there's any cost incurred in this bill, Mr. Chair, I would submit that the long-term effects on saving in cost for our school districts, our healthcare system, are far, far outweighed with the benefit that having healthy kids born drug-free brings to our society. So I would just say that CRAFT program was so successful, it was expanded regionally, and now I don't know, I'm assuming there's some quite relation here, but to see this statewide is so important. And maybe if I could just share with the committee briefly, my first year teaching as a special education teacher, one of my students, a first grader, had fetal alcohol syndrome. And if you've not worked with a young child who has FAS, it's important to know they have significant learning challenges, among other things. And so I just think this is one of the best things we can do, is to make sure that we have more and more of our children born drug-free. So I'm just highly supportive. Thank you, Senator Draheim, for bringing this.
Thank you. Senator Benson.
Thank you, Mr. Chair, and I just want to clarify, Ms. Kavanaugh, other than changing who the report goes to, there is no new language associated with these grants, and Mr. Albrecht, no new funding associated with these grants.
Ms. Kavanaugh or
correct?
Mr. Albrecht? Mr. Albrecht.
Madam Chair and Senator Benson, to the second question, no, there's no new money. And to the first question, if you look on the last page, I'm pretty sure it's word for word just taken out of DHS statutes and moved to MDH.
Thank you. And Mr. Chair,
Senator Benson.
I tried to compare the engrossments. I just wanted council to make it clear so nobody thinks we're creating anything new. We're just moving commissioners. So thank you, Mr. Chair.
Thank you. Members, anything further? Questions, comments? Seeing none. Senator Draheim, final comments?
Thank you. When Sarah brought this to me, I said, heck yes, let's do this. I have a sister-in-law that does foster care for babies that didn't make this program. And it's really hard to watch what happens with those babies, the infants that didn't get the help, the mothers that didn't get the help. So if we can make a difference and make the program run better by moving from one agency to the other, let's do it. And then let's have the discussion next year when it's a budget year about the funding. So thank you, Chair.
Thank you, Senator Draheim. And if you would like to renew your motion that Senate File 3574 be recommended to pass as amended and sent to Finance.
So moved.
Thank you. Members, we have a motion before us. All those in favor signify by saying aye. Aye. Opposed? Motion passes. Thank you, Senator Draheim.
We get 10 minutes per bill.
We're on to 3 o'clock.
Senator Coran has Senate File 1847 before us. Senator Coran, when you're ready, if you would like to move your bill.
Thank you, Mr. Chair. I'd like to move Senate File 1847.
Okay, Senate File 1847 is before us. I know that you have an amendment, but if you'd like to introduce your bill first or whatever you'd like.
Mr. Chair, I think let's just get it cleaned up. It's a delete all amendment, so let's just get that taken care of and then we'll speak to the bill. So I'd like to move the A2 amendment to Senate File 1843, or 1847, sorry. This is the first stop.
Yep, thank you. Senator Coran moves A2, which is an author's amendment, being a delete all. So all those in favor signify by saying aye. Aye. Opposed? Amendment is adopted. Senator Coran, to your bill as amended.
Thank you, Mr. Chair. And we often have spent many years working on some topics, and this is one that we've spent quite a bit of time on. So I think it's great that we're going to be able to move it to a conclusion that's amenable to everybody and make the necessary changes. So this bill, for the past couple of years, we've worked with funeral directors and others and interested parties about licensed funeral directors and the ability to move a dead human body from place to place. It's been controversial because of the licensure requirements, and those inside and outside the funeral service have been weighing in. We've had strong opinions. We've worked with everybody impacted by these proposed changes. Current Minnesota law requires licensed funeral directors to make removals. Under the governor's waivers during the peacetime emergency, unlicensed individuals under the supervision of a licensed funeral director were permitted to make these removals. Minnesota's Funeral Director Association and other stakeholders, including licensed funeral directors and unlicensed individuals, have worked to achieve this agreement for removals by unlicensed individuals. It's a pretty significant change to the entire funeral profession. What Senate File 1847 does, it amends and permits unlicensed individuals to make removals given that they comply with these conditions. They register with the Department of Health, they complete 7 hours of training, and always operate under the supervising, somebody with the supervising license. It also amends and also permits that a licensee can supervise up to 6 unlicensed individuals. This has been worked on for multiple years, and many different opinions have been held regarding this topic. The legislation also provides for a new option for funeral establishments to carry out duty of removals from the place of death while maintaining public health and the dignity of the deceased. In addition to the removal language, there are 2 more provisions as well. The bill extends the time a body can be held in storage to 30 days, with an additional 30 days allowed by notifying the Commissioner of Health. Similar extension was also provided for human remains, was permitted under the governor's waiver under the last peacetime emergency. And then the second component is the creation of the cremation of a limb is permitted, and cremated remains can be returned to the individual. This is a clarifying fix. Otherwise, the funeral homes cannot do this. So with that, Mr. Chair, I think we have 2 testifiers. So I'd like to first call up who's sitting next to me. Mark Schultz. He's with the what's that?
I'm Brian.
Oh, I'm sorry, Brian. I'm reading from the wrong notes. So, Brian,
thank you, Senator Coran, and welcome, Mr. Dingman. Thank you for joining us today. Please identify yourself for the record and proceed with your testimony.
Thank you, Chair Uckey and members of the committee. I'm Brian Dingman. I'm a licensed mortician and co-owner of Dingman Funeral Care. I'm speaking on behalf of the Minnesota Funeral Directors Association, which is made up of more than 600 licensed funeral directors and over 200 licensed funeral establishments. We want to thank Senator Coran for his work on Senate File 1847 as amended and helping to gain consensus among stakeholders on this issue. This new language represents agreement among the many different voices within the profession and those seeking to enter funeral service. Over the past few years, the idea of non-licensed individuals practicing mortuary science has been proposed. And as with other licensed professions, the idea has been a challenging one. MFDA knew that many arguments both for and against were valid, and we needed to address the issues, specifically on removals by unlicensed individuals, the duty that current law requires to be carried out by a licensed mortician. In order to gain a clear understanding of where the profession stands, MFDA gathered member feedback through member meetings, as well as a survey of MFDA membership. Additionally, MFDA provided input on a research study conducted by the University of Minnesota Medical School's Program of Mortuary Science, which assessed funeral professionals' attitudes toward policy changes, including the topic of removals by individuals other than licensed morticians. This study included MFDA members and non-MFDA members. Obtaining the data was critical in understanding the direction the profession should go. Using this feedback, we had a goal of finding a compromise among the many different opinions to allow those who are not licensed morticians to make removals. Most important to MFDA members was the inclusion of measures that require licensee supervision, Department of Health oversight, and appropriate training to protect the public health and dignity of the deceased. Senate File 1847, as amended, accomplishes this goal. Primarily, it permits individuals other than morticians, referred to as transfer care specialists, to make removals from the place of death. It requires these individuals to register with the Department of Health, which provides a department with oversight of the individual. This oversight is critical so that there is recourse in the event that there is a complaint or the health needs to investigate. It also requires supervision by a licensed funeral director. This supervision ensures that corrections can be made to avoid improper practices. Finally, it requires 7 hours of training to be completed every 5 years. This training is an important piece to ensure that the transfer care specialists know proper removal procedure, potential health and safety concerns to the individual and the public, and the ethical care of the decedent. The removal is often a family's first interaction with a funeral home and a funeral professional immediately after a death, and it's important to get this right as we don't get redos in our industry. Senate File 1847, as amended, is truly years in the making, and we appreciate all the stakeholders who weighed in. It will provide a new option to carry out the duty of removals and will give new opportunities for those looking to enter the profession. Again, I want to thank Senator Coran for helping us get to this point, and Chair Uckey and the committee for your time. Thank you.
Thank you. Next, I've got up here showing Megan Forbes.
Mr. Chair, I believe she's online instead of in person.
Yep. So I see her online. So Welcome, Ms. Forbes, to our committee, and please identify yourself for the record and proceed with your testimony. I was
going to say you have to sign in. But
Thank you. Good afternoon, Mr. Chair. My name is Megan Forbes, and I'm Legislative Counsel at the Institute for Justice. We're a nonprofit law firm that works to protect civil liberties, including economic liberty. We support this bill because it removes unnecessary barriers to working in the funeral industry. It will also provide some relief to funeral providers who are facing staffing challenges right now due to the state's approach to licensing. Minnesota has the most burdensome licensing requirements in the country to work in the funeral industry. While most states require a 2-year associate degree, Minnesota is one of only 2 states that requires a bachelor's degree. So people often start out working in the industry here with more debt than they do in other states. The state's approach to licensing is placing a strain on some funeral providers, especially in rural parts of the state, where there are not enough licensees to go around. This bill provides some relief. It formalizes a licensing waiver from the pandemic, and because of this waiver, more than 100 unlicensed trained people registered with NDH to conduct removals. Moving forward, we hope that NDH will continue to allow transfer care specialists to receive the 7 hours of training that this bill requires from their supervisors, and will approve that type of training. We also encourage the consideration of other reforms that allow unlicensed people to assist with funeral planning under the supervision of licensees. This kind of reform would give licensees who are facing staffing shortages the flexibility they need to operate and to continue offering their much valued services in their communities. Thank you again for the opportunity to testify and for your consideration of the reforms in this bill.
Thank you. Members, any questions, comments for Senator Cran or testifiers? Seeing none, Senator Cran, final comments?
Thank you, Mr. Chair. It's good to bring something to an effective conclusion, bringing all parties together over many years. And so with that, Mr. Chair, I have no further comments, and what I'd like to do is I'd like to move that Senate File 1847 be recommended to pass as amended and sent to the Finance Committee.
Okay, thank you, Senator Cran. Members, we have a motion before us. All those in favor of the motion, please signify by saying aye.
Aye.
Opposed? Motion passes. Thank you, Senator Cran, and your testifiers. Oh. Okay. Now, Senator Cran has before us Senate File, or bringing to us Senate File 61. So if you would like to move your bill, Senator Cran.
Thank you, Mr. Chair. I'd like to move Senate File 61.
Okay, Senate File 61 is before us, and
Mr.
once
Chair?
again, you do, okay, go ahead, Senator
We do
Cran.
have also have an amendment. It's the first stop, so as an author's amendment, I'd like to move the A2 to Senate File, A2 amendment to Senate File 61.
Okay. Senator Cran has moved the A2 amendment. Everybody got a copy? All those in favor signify by saying aye. Aye. Opposed? Amendment is adopted. Senator Cran to Senate File 61 as amended.
Thank you, Mr. Chair. And I'll just cover the amendment itself. The significant change to it is it changes on line 321 from after disorder. We insert and add mental illness in addition to drug addiction. And so it covers a broader spectrum of injectable drugs and more unifies it across all needs in the industry where this type of injectable drug is beneficial. And then in line 3 on 29, of course, changes from administering practitioner in pharmacy and inserts the commissioner. So with that, Mr. Chair, I'll attempt to make the statements as brief as I can, but it's a complicated issue. And again, another opportunity to hopefully bring to a close a bill that I've worked on since I came to the legislature. So with this bill, the Senate File 61 is really, it's been known through our committees as the buy and bill bill. And what it does is that this file actually removes access, barriers to access for physician-administered drugs to treat substance abuse disorder and mental illness. Providing access to medicines to treat substance use disorder and mental health is increasingly important priority as we're dealing with the increased substance use disorder and mental health issues over the past couple of years. What this bill does is it provides an option for providers to use buy and bill method and or pharmacy benefit, whichever works best for their particular practice. These medicines can be provided in an injectable form that lasts for several weeks or even months, allowing the patient to focus on well-being rather than the daily struggle to take medications to remain stable. This class of medication is referred to as physician-administered medicines. In Minnesota, we're only among 25% of the medical assistant population is covered under our fee-for-service Medicaid plan. Your access to physician-administered medicines, the class of medicines that are injectable or implantable, is severely limited. Although our Medicaid fee-for-service program covers these medicines, it is only covered as a medical benefit through the process of buy and bill rather than the traditional pharmacy benefit. Buy and bill itself is an arrangement through which the healthcare providers purchase pharmaceutical products directly from a wholesale or specialty distributor, enable them to have a supply of provider-administered medications on hand for treatment of patients. The term itself is what it is. It's a reimbursement model. It requires the healthcare provider to buy these medications up front and then bill for the patient's insurance for the reimbursement of that medication. So physicians have to store it, maintain it, buy it, and pay for it, and these can be extremely limiting to small providers. Healthcare providers don't receive payment for these medications until their patients' insurance claims are processed and reimbursed when covered by the payer. Many small healthcare providers and practices and clinics don't have the administrative staff necessary, overhead, or the resources to manage this type of inventory control, billing systems, and upfront costs. So these patients, in effect, in many cases, don't have access to long-term and long-acting injectable medicines. They're instead given oral medicines, which must be taken daily, which might be fine for some patients, but in most severe cases, and in many of the treating substance abuse disorder and serious mental illness, such as schizophrenia, the medication adherence can be problematic. Minnesota is only one of a handful of states that still require this process. We are an outlier. Removing these barriers to treatment, or access to treatment, is why the Opioid Epidemic Response Advisory Council, which I'm a member of, along with Senator Kunish and previously Senator Eaton, we've included this in our policy change as a legislative priority. As a state, we need to update our statutes to make sure everybody gets the best possible care rather than making decisions based on the types of reimbursement model, forcing others to either seek treatment or elsewhere or leave and not seek treatment. Mr. Chair, that concludes my statements, and I think we just received the fiscal note, so if we could have Mr. Albrecht kind of give the walkthrough of the fiscal note prior to our testifiers, we'll be all set.
Thank you, Senator Cran, and Mr. Albrecht, if you would like to go over the costs of this bill.
Mr. Chair, Senator Cran, and members, as you can see on the front of the fiscal note, in the middle there are the amounts, the $390,000 in fiscal year 2023, and then $719,000 and $740,000 for the next biennium. Chair. On the next page under the assumptions, I think the fiscal note was drawn under the assumption that it would be effective on January 1st, 2023. And then at the bottom of that page begins the discussion of the calculations that were used. There is the second paragraph there talks about the number of current recipients for the drug that they assume would be affected by the change. It's called naltrexone, I think. And then the paragraph below that talks about the fact that having this new methodology would allow additional people to receive the drug, and it talks about the additional doses and the cost per dose that would go along with that additional use. That's the bottom of page 2. Sorry, I should have pointed out that was for substance use disorder treatments. And then on page 3, at the top, there is a similar section talking about injectable drugs for mental illness. Again, the first paragraph talks about the current usage, and then the second paragraph talks about additional enrollees and additional doses. And the last paragraph in that section talks about the effect on pharmacy rebates from buying the additional doses. And in the next to the last paragraph there talks about the rate coming to a weighted average pharmacy rebate of 14.2%. And the last section talks about the administrative costs that are attributable to the part of the amendment that Senator Curran described that has the commissioner rather than the practitioner or pharmacy, ensuring that the claims are not duplicated, the payment for the drug. And goes on to describe the kinds of positions that would be needed and what they would do. And on page 4 at the top there talks about additional costs attributable to the Office of Administrative Hearings for provider appeals. And then the rest there just all are all the calculations that lead to the amounts on the front page. And on the last page, on page, sorry, not the last page, page 5, in the bottom of page 5 is the summary. The first 2 lines are the costs attributable to the increased doses, and then the other 4 lines reflect the administrative costs that were discussed.
Okay, thank you, Mr. Albrecht. And we will then, or now, go to our testifiers. First up, we have Pamela Schultz.
Mr. Chair, I believe she's online.
Hello.
There she is. Welcome to our committee.
Thank you. My name is Dr. Pamela Schultz. I am representing the Minnesota chapter of the American Society of Addiction Medicine. I myself have been an addiction medicine provider for over 14 years, and our over 100 members of the MinSam are all specialists in providing treatment for substance use disorders. We are in support of this bill for several reasons. Number one is that we see many patients who are unable or unwilling to take oral medications consistently, or just are not able to be compliant due to mental health issues or other issues. Many of the patients that we see for substance use disorder are homeless. They have no safe place to store medications. Medications are lost or stolen frequently in those kind of shelter settings. These medications treat several types of substance use disorders, including opiates, but also alcohol. And I was just thinking, having listened to Senate Bill 3574, that one of these medications may actually be helpful for pregnant women with alcohol use disorders. So, but furthermore, these medications have been shown to give steady blood levels continuously throughout their dosing period, which can be, as Senator Curran said, 30 days or so, or longer. And so they provide a more continuous therapy than a pill where the levels are changing, within the 24-hour range. More importantly, I think it's important that Medicaid patients should have equitable and similar access to medications to these medications that others do. We are quite focused on trying to provide equitable care to all citizens in Minnesota who have substance use disorders. And I think this would allow them to receive these medications, which can be very helpful. They've been shown to be cost-effective in many ways. We know that medication-assisted treatment for opiates reduces mortality, it reduces the risk of overdosing. Patients are more likely to stay in treatment when they are on medications to help treat their substance use disorder. And they have been shown to decrease the likelihood of patients contracting acute infections from IV drug use or chronic infections such as HIV or hepatitis C. So we know these medications are effective. The current buy and bill system is a significant barrier to many addiction medicine providers being able to provide these medications. Number one, logistical reasons, as mentioned, storage issues. They aren't always, their expirations are such that if it's not given within a certain amount of time, it's therefore can't be used, and so cost of medications that are not used is significant. And availability. Small clinics in rural areas have trouble accessing these medications in a timely fashion when they have to go through the process of specialty pharmacies. For all of those reasons, we support the Minnesota Medicaid program in removing the buy and bill requirements for these substances, for these medications. Thank you.
Thank you, Dr. Schultz. Next up, we have Chad Hope from the Department of Human Services. Welcome to our committee.
Good afternoon. For the record, my name is Chad Hope. I'm Deputy Director for the Division of Purchasing and Service Delivery at DHS. Wanted to make a couple of comments about the bill from the department's perspective. The first iteration, as stated earlier, would have primarily impacted Vivitrol. The A2 amendment, as also described, would increase the number of medications to include not just injectable naltrexone and the associated drugs, but injectable drugs to treat mental conditions. These medications have a much higher rate of utilization, and the universe of medications now included in this bill would be substantially larger than the initial version. For both of these types of drugs, both the mental health drugs as well as the naltrexone, the language would allow for dispensing pharmacies or specialty pharmacies to bill DHS for the drugs, which are then intended to be administered to our enrollees in an outpatient clinic setting. The current law limits the payment to clinic-administered drugs to the administering facility or practitioner on the same claim as the office visit or the administration fee. One thing I want to highlight that's important here is all of these drugs are currently covered, and this bill does not impact whether or not we're adding coverage of these drugs. It is simply impacting the payment policy by which the drugs are reimbursed. The current structure that we utilize to reimburse the administering facility minimizes waste by not introducing the potential for double billing by both the dispensing pharmacy and the administering clinic. And it also allows the clinic to adjust the doses for the medications on the day of the appointment because the medications haven't been pre-dispensed for a unique member, having to be set aside and maintained for that unique member at that unique dose. Allowing for on-demand dosing adjustments not only eliminates wasted doses that are dispensed but not administered, but it also allows providers to quickly make necessary dosing changes to the regimens. As we've communicated previously, allowing for white bagging presents a number of administrative challenges to Minnesota's medical assistance program. The first is the language would separate the payment of the drug from the administration of the drug. Without administration and drug costs on the same claim, the only way to verify that payment for the drug was not the result of a duplicate billing when multiple claims are present is to conduct post-payment reviews. With the increased universe of drugs included in the 2A amendment, the need for administrative resources to ensure the drugs are being appropriately administered to the correct MA members would increase. Secondly, additional drugs that are dispensed under white bagging model are specific to an enrollee. If an enrollee does not present for an appointment or the provider changes the drug or dose, the previous drug dispensed is not able to be used for any other member. This will result in the wasted drug that is reimbursed by MA but not administered to a member. Thank you for the opportunity to outline these concerns.
Thank you. And we'll move into questions, and I have Senator Abeler.
And there's many things to talk about here, but I'm just, what you're saying, Mr. Hope, is that actually this fiscal note is low, then it'll cost more because of the amendment. Is that just, is that what you said?
Mr. Hope?
Mr. Chair, Senator Abeler, the fiscal note, I believe, is specific to the 2A amendment. There are components of the fiscal note that are not captured that I mentioned, such as the waste. I do not believe we were able to attribute an assigned cost for waste.
Well, that's fine.
Senator Abeler.
That's not key to my point. I was just adding up how many people, you're going to see maybe 200 people more according to your fiscal note. You need 3.5 FTEs. A lot of us wonder what FTEs do all the time, and I guess it's more of a comment. Can I say my head wants to explode once in a while, Mr. Chair? Is that legitimate? Yesterday we were told it's going to take $10 million worth of administration to pass out $300 million worth of grants, and it's going to take 8 to 10 months. And now we're being told it's going to take 3.5 people full-time. That's like, and I just did it, 3.5 people divided into 171, that's 48 a year, so they're going to do one a week. So I don't know, I find this frustrating, and I don't know you very well, Mr. Hope, but you're in a department who knows how to hire people, and I don't know what they all do. They work hard, but you always want just like a blank check for more people, and I just think you overshot this one. Thanks.
Thank you. Senator Eaton.
Thank you, Mr. Chair. And I want to thank Senator Cran for carrying this bill. This is something I've also been working on for many years. And it's with great relief that I see it reaching a conclusion. I recognize that the Department of Human Services has concerns about billing processes, but I don't think that those should supersede the equitable access by people on medical assistance and the advantages to having Vivitrol available for people with opioid use disorder. So I strongly support this bill, and again, thank you.
Thank you. Senator Benson.
Thank you, Mr. Chair. Mr. Hope, could you remind us again how many claims you would have to review through the course of a year with 3.5 FTEs?
Mr. Hope.
Mr. Chair, Senator Benson. So the review would actually encompass all claims for these drugs, because it would introduce the potential for any of these drugs to be dispensed from both a pharmacy and then billed on the medical claim. So the reviews themselves in the first stage for the data review is going to have to include the entire universe. Once there are potentials identified for duplicate billings, that would have to then go to a post-payment review to identify whether or not there actually was a duplicate billing, because the clinic may have purchased the drug separately as well as having a pharmacy dispensing it. So it would really be situationally specific for each claim they have to chase down.
So,
Senator
Mr. Chair,
Benson.
Mr. Hope, how many claims would you have to review?
Mr. Hope.
So, Mr. Chair, Senator Benson, it would be all claims, but the degree to which they would have to be interrogated would vary.
Mr.
Senator
Chair,
Benson.
how many claims, just the number that are in that first stage of review?
Mr. Hope.
Mr. Chair, Senator Benson, so using the fiscal note, looks like the assumption on the Vivitrol would be 146 plus 432 And then for the mental illness drugs would be 2,763 plus, I think it's about the same number, 432. So it's probably going to be in the, what, 4,000 range?
Senator Benson?
Mr. Chair, Mr. Hope, how many hours does it take to review those initial claims per claim?
Mr. Hope?
Mr. Chair, Senator Benson, that we don't know yet because we haven't built this process.
Senator Benson?
Mr. Chair, we don't know how many hours, but we're absolutely certain we need 3.5 FTEs to do it.
Mr. Hope?
Mr. Chair, Senator Benson, that is correct. That's what the fiscal notice is.
Mr. Hope,
Senator Benson?
you just told me you don't know how many hours it's going to take to review the claims. At 4,000 claims a year, if it took 2 hours per claim, let's see, if it took, so an hour per claim is 4,000 hours, that's 2 people working a normal full-time year with 2 weeks paid vacation. So if it's an hour per claim, then you need 2 people. So how many hours will it take per claim?
Mr. Hope?
Mr. Chair, Senator Benson, by rough multiplication out, yes, it'd be 2080 times 3.5 would be the number of hours we're anticipating. It's not just the claims review, it's also the administrative hearings and then the operations associated with having to do any takebacks of duplicate claims.
So, Mr.
Senator
Hope,
Benson.
can you show us that math to get us to 3.5 FTEs? That's what fiscal notes are for, Mr. Hope.
Mr. Hope?
Mr. Chair, Senator Benson, I do not have a descriptive, formula to get you to that, no.
So, Mr.
Senator
Chair.
Benson?
So the 3.5 seems like a back of the envelope, and so maybe we shouldn't fund things that are back of the envelope. It's a reminder to Mr. Hope, fiscal notes are advisory. We can pass this with whatever amount of money we want to. So members of the committee, as much as we might have budget rules, if Mr. Hope can't tell us how many hours he's going to have to spend per claim, there's no reason to give him this money.
Thank you. Next up, Senator Nelson.
Well, thank you, Mr. Chair. Senator Cran, I understand,
I think your mic is off.
Is it on now? Yes?
There, now we hear you.
Yes, all right. Thank you, Mr. Chair. Well, Senator Cran, I think I understand the gist of why this bill is important. I mean, I do know with mental health particularly, one of the most difficult things is adherence to those drugs that make such a difference. One starts feeling better and then stops taking the drug because, well, I'm feeling better. But then, of course, things change. So, but I do have to understand, does this bill, here's my questions first. So I'm a little bit confused. Looking at the fiscal note, it looks like this only applies to mental health drugs, or does it also apply to substance abuse disorder drugs? We know that these two things travel together a lot, but I do just want to understand what the bill language includes and what the bill fiscal note includes. And then my other question does have to get to whom does it apply? There's been a great deal of talk about medical assistance, so it applies to patients using MA. But what about patients in the private market or in other fee-for-service? So those are like two big questions that I'm trying to get a clearer answer on.
Mr. Chair.
Senator Cran.
Yeah, Mr. Chair. Senator Nelson, originally the bill was buy and bill was focused on the substance abuse disorder. But the same issue has arisen in mental health for the very same reason, and the consistency and utilization of, or the compliance in taking medicines that are non-injectable, which are long-lasting versus the daily requirement or regimen to do that. So the addition or the enhancement was to add mental health into it as well for the very same reasons. And then from the fiscal note perspective, it was to cover the providers, the middle and small providers who treat both mental health and substance abuse disorder struggle to have the upfront financial resources to be able to buy those resources and have them on hand versus utilizing the traditional pharmacy benefits from the perspective of like all other pharmaceuticals. So this buy and bill creates a burden from them administratively as well as the financial liability in carrying that inventory because they have to pay for it up front and then reimbursable on the back side. So it really impacts most of the medium and small providers who serve our rural communities all over the state, and it does then expand it to those that are most disadvantaged or most impacted by it, many on the Medicaid on our benefit side. So they don't have the accessibility. This increases it across the board, and the cost of not doing this is far greater than the cost of life and the cost of all of our other programs. And so when we look at these, and we can debate the fiscal note, the overall costs that we incur indirectly in other forms of government are far greater.
Senator Nelson.
Oh, thank you, Mr. Chair, and thank you, Senator Coran. So it impacts all insureds, whether they be on medical assistance, private pay, fee-for-service, all would be treated the same under your bill. I'm just checking that.
Senator Coran. Mr. Chair and Senator Nelson, that is my understanding, and then it creates, it adds the option. So instead of being forced to utilize buy and bill for these injectables, it allows it to be, allows them to both buy and bill and or the traditional pharmacy benefit.
Senator Nelson,
Thank you.
and we're kind of running up against the clock, and I do want to get to Senator Benson because we'll be bringing this back for a little bit more conversation next week.
Final comment then. I look forward to that further discussion because I am cautious about the bill in its current form. I understand the intent, but I'm just not confident that this is the way to best address that. So I'll wait for your further discussion.
Okay, and I encourage you to have conversations with Senator Coran in between, but Senator Benson, you would like to address that fiscal note.
Thank you, Mr. Chair. Mr. Hope, I'd like you to revisit the fiscal note and show us how you came up with 3.5 FTEs based on the hours you think it will take to cover those claims. Because if it's 4,000 claims at an hour per claim, that's only 4,000 hours of work. And you're asking for well more than that and a very high level of expertise and a high level of FTE burden that you're putting on this bill. And so for Monday, Mr. Chair, I think we need a revised fiscal note from Mr. Hope.
Thank you, Senator Benson, and Mr. Hope, I think you got the comment from Senator Benson that we would like to have you, if you could have that ready for us Monday for our committee hearing, we would look forward to seeing what it looks like. And Senator Abeler, you want to weigh in before we...
Just very brief, and I was reacting to the fiscal note. Senator Eaton clearly said the value, but I just want to point out that these fiscal notes sometimes deprive us the chance to do what we really want to do. Both on utilization, which is guessed at, staff, which is guessed at, and we have a budget we have to hit. And so many good things don't happen because that's why we're so stirred up here. So not about the bill, but just like historically these fiscal notes. Thank you, Mr. Chair.
Thank you. Thank you, Senator Coran. With that, we will lay this bill over for today, and we'll have further conversations next week. With that, we will stand adjourned. Thank you all for staying around for an extra number of minutes here to further conversation. We are adjourned.